Thank you for joining the Class Connect Shoulder Instability webinar organized by COMEC. I'm Dr. Ng Wei Ming, currently working as an orthopedic consultant in Malaysia, special interest in shoulder and knee surgery. Today we have three very interesting topics lined up for this webinar. After the webinar, there will be 10 minutes of question and answer session. So for the participant or whoever want to ask any question, you can start to type up your question in the chat message box there. So we will try to answer your questions by the end of after we present, three of us present the talk. So I would like to introduce the other panelists on the board. Dr. Yao Wei Pang, professor from Hong Kong University. He's going to he's going to share with us a talk of the arthroscopy Bancha repair. And the Dr. Bancha, the last speaker, will talk about shoulder instability in elderly. So without any delay, I will proceed with my first talk first. Fracture dislocation with a large bony fragment from glenoid using arthroscopy ankle suture repair.
Yes, very well. Prof. Let's go.
So I'm talking about glenoid fracture in a fracture dislocation of shoulder. The prevalence of the glenoid fracture happen in first time dislocation is around 60%, 38% in recurrent dislocation, and they poses a higher rate of instability. We have a long-term impact of this fracture, which cause osteoarthritis of the glenohumeral joint. So classification of the fracture glenoid by Heidelberg, actually they include the fracture of the scapula also. What we interested today is just mainly fracture glenoid, intra-articular part of the glenoid, type 1A and 1B. So Gliani, 1999, share a very nice classification which is used mainly for practical purpose. He divides the fracture glenoid in the shoulder dislocation in three types. Group 1 with the avulsion fracture, Group 2 with the avulsion fracture and also the rupture of the capsule labium complex, where the bony avulsion heal mean more medially and inferiorly. We have group 3 that's divided to A and B, depend on the glenoid bone loss, whether it's more than 25% or less than 25%. So to diagnose this fracture glenoid, X-ray sometimes is not adequate because if you're very lucky, you can see the glenoid, broken glenoid piece. You will follow the line, the cortical line of the glenoid in the AP or AP view. But most of the time you'll miss it. So you need to look hard for this, especially after you do a CMR for the shoulder dislocation. MRI, yes, MRI is good to look for bony structure and also the ligament, any capsule, any cuff tear or any associated injury. If you want to study how much the bone loss is, I think CT scan is a better imaging to look for. So you can study using the end-on view of the CT scan. With you ask your radiographer to resect the humerus. You remove the humerus and look the direct end-on view on the glenoid. Then you can appreciate how much the bone loss is. So bone loss, glenoid bone loss, we know that tends to have associated with the great instability of the shoulder. So the most famous, one important study by Bukat in 2000, they show that there's two types of bone loss. One is a reverse pear-shaped glenoid bone loss and the engaging HUSAC. So they study 194 patients, follow up for 27 months. They found that there's 21 cases with recurrent dislocation. That means the fail after Bancha repair. And they further analyzed among the 21 cases of fracture recurrent dislocation, 14 cases, 64% actually have a critical bone loss, either on the glenoid side or on the HUSAC. Whereas only 4% failure of the Bancha repair if there's no bone loss. This shows that with bone loss, there's a lot of stability despite you do a repair. So the other concept by Professor Itoy, glenoid tract. This interesting concept. They study the contact surface between the humerus head and the glenoid, with the shoulder abducts from neutral to abduction and external rotation position. So they study the glenoid. The glenoid sit on the humerus head sit on the glenoid throughout this motion. So they come out the other concept of the on track and off track. This is very interesting. You can see that. So glenoid bone loss usually associated with mid-range instability. Well, the hillside lesion is an end-range instability. But look at this on track and this is the on track. This is the on track. You can see that the head is sitting on the glenoid throughout the range. Well, if there's a bone loss in the glenoid, so the tract is smaller, so the humerus head will dislocate. So you need to appreciate that how much bone loss will causes this instability. So if I go further to study the glenoid bone loss, using the measure the glenoid bone loss using two methods. One is circular method, the other is using a vertical method. So he reset the glenoid using two methods. One is oblique, the other is vertical. So they reset about 9, 11, 19 or 25%, and they study throughout the arch of motion and which glenoid bone loss will cause instability. So they come out with the idea, the figure is, if they reset the glenoid using an oblique cut, so if there's a glenoid bone loss about 21%, the shoulder is unstable if you do only a soft tissue Bancha repair. Well, if you reset the glenoid in a vertical line, so if there's a 25% of glenoid bone loss, so this causing a gross instability. So you need to think of a way how to augment the bone loss or how to repair the bone loss on top of the soft tissue repair. So indication to when should we do a repair for this glenoid bone loss? All right. So any fragment we understand is any bone loss more than 25%, we should consider do a repair, and any displacement more than 10 mm. Or we look at the MRI or CT scan, we see that the humerus was decentral. That means it's not sitting on the center anymore. So this is an indication we go for the surgery. Previously, to do the glenoid ring fracture repair, usually you do an open repair. So Bilyani group did the repair. Out of 200 patients, they do open repair. 25 patients still have a recurrent dislocation. So you can see that for type 1, 16 shoulder. For type 2, 5 shoulder. For type 3, 3 shoulder. Type 3A, 1 shoulder. So in this paper also, Bilyani noted that X-ray only can noted 19 out of 25 patients of the shoulder dislocation have the glenoid ring fracture. Well, the overcade CT arthrogram is still the best to study the glenoid fracture dislocation and also to study any capsule division. For the open surgery done by Bilyani group last time, previously, they found that they still have 3 patients with recurrent dislocation, one from the grade 1 group.
Yes. Is there any questions from the participants? So I saw some questions they sent to me personally. So about the limb research, Peter. Some audience they asking about the limb research. Do you think limb research plays some roles to provide the stability of the shoulder joint, Peter?
Yes, definitely yes. This is why I'm doing limb massage in the past 10 years until 2 to 3 years ago. Because if there's a large hillside, but the glenoid defect is not that significant, you need to adjust both the Bancha lesion and also the hillside lesion.
Yes.
At that time, the way for me to address is to do a Bancha repair and also a limb massage procedure. I'm happy about the reduction in the dislocation rates, just like that is shown in the literature. It's quite very acceptable. But what I don't like is in some of the patients, they do have a loss of external rotation. And in a very minor group, they also have some pain. But at that time, that means 4 to 5 years ago, I don't have any good method.
Yeah.
But not until 3 to 4 years ago, I tried to separate the labral repair and the capsulorrhaphy with the surgery that I showed you in my last part of the presentation. After doing half to 1 year, I found that actually the dislocation rate is very satisfactory. And then I extended to those with a significant heel substitution, but of course, no significant glenoid problem. And I also found that actually the result is quite good in terms of recurrent dislocation rate, but they don't have the problem of the external rotation loss or posterior shoulder pain. This
Yeah.
is why now I'm not doing massage anymore.
Oh,
But
really?
you can challenge it in a way that, well, you don't have enough follow-up. Maybe a few years later, the dislocation rate come back. It may be the case. But I'm
Yeah.
just saying at the present moment, I think it's still quite satisfactory for my result.
Yeah.
So as a result, I will prefer to stick with this maneuver.
How about you, Prof. Ng? Do you love limb massage or not? Do you have any problem about the external rotation loss in your experience?
Yes, I noticed that few patients of the repressors, there's some limitation of external rotation. But I think it's a beautiful procedure because you don't need just additional around 30 minutes. You can fill up the heel sac with the infraspinatus muscle and tendon. So the only is external rotation, but it's not very. I don't have experience of very severe limited external rotation up
Yeah.
to 20 degree. Just a mild external rotation. But usually after a while, if the patient, if you don't tell them, they won't realize that there's a limitation.
Yeah.
That's the experience.
So I also have no problem about the external rotation loss. Some surgeons don't believe in limb massage, like your boss, Professor Younger Lee. You remember? So he, at that time, I think he showed us one patient that the ligament dislocation many times. He did to do the revision for this patient, and finally, the last operation he did the limb massage for this patient, so he can solve the problem. So I think it's true, but I believe Professor Yongali, he's very honest. Yeah, so that's why I believe in limb massage. Yeah. So Peter, your mention is also your comment is also important. I will look in my patient any problem because I think sometimes if you repair the muscles into the defect, you may create some problem, right? You should repair the
Correct.
tendon into the defect, right? Should not go to
It's
medial.
because the tendon or
Right.
the posterior capsule,
Yes.
definitely not the muscle.
Yeah, not the muscles. Yes. Very good. So that's some Q&A for Professor Ng. Which portal you can do double row fixation, the fragment? Professor Ng.
So I use a standard anterior portal and add additional anterior superior portal. So to hold the fragment, then after that I will put the suture and tie it. For the second question, reduction of bony fragment usually is not an issue because you do it fairly early. Usually you need to do it before 3 months, most of literature, but usually I do it within 1 month or 2 weeks. So temporary fixation, if a big fragment, you can use a K-wire to drive through, but usually you holding with your grasper of the labrum and capsule complex, not direct on the bone piece, tensioning of the IGHL in the soft tissue bronchi. Then using the suture, you can slowly reduce it and fix it on the place. Of course, may not be 100% edge to edge the fixation of the fracture, but you can bring it back to the defect and fill it up with the bone and also the capsule labrum complex. That's adequate.
So thank you, Ng.
Yeah.
For Professor Yao, Peter, there's a
Yes.
question for you. How can you balance both size, bone loss, and the glenoid and the humerus to do limb massage or not? How can you
Actually,
balance?
I don't really understand the question. I
Yeah.
suspect he is asking how to assess the bone loss in order to decide whether to do a ramp massage or not.
Yes.
If it is the case, the first thing I would do is, if it's a recurrent shoulder dislocation, say 5 times 10 years, I will routinely perform a CT with 3D reconstruction showing the end-on view of the glenoid. Because the first thing affect my decision is the glenoid size.
Right.
If it is less than 20%, I will not do the glenoid surgery. If it's more than 20%, I will do the glenoid surgery. In those doing the glenoid surgery, say either letter J or eating hibernate procedure, that means crest bone graft, I will not need to do a ramp massage, simply because the bone process is so good, it take care of any other things.
Yeah.
But if the glenoid bone loss is less than 20%, I will decide to do a soft tissue procedure. 3 years ago, as I mentioned, I will do both ramp massage and Bancha repair if the heel size is large. Then the question comes, what is large? This is a tricky question. I don't use a CT to assess. I just do an arthroscopic assessment, and I feel, oh, this one seems worrying to me, and then I will do a ramp massage. But to
Yeah.
be honest, there is no good quantification here. But nowadays, as I mentioned, if it's less than 20%, I will simply do a capsular plication together with my Bancha repair and skip the ramp massage.
Okay. There's one question for me. He asking me about the osteoporotic problem. Okay. So in this situation, how to manage this osteoporotic problem? How to choose the anchor? So I will tell you the why not is pretty good because in osteoporotic bone you don't need to make a pilot hole, no tapping, right? And you can change the direction in case you want to put the why not at the humeral head. Try to go into the subchondral bone, not perpendicular. If you go perpendicular, it will be soft bone. So you can put it deeper into the subchondral bone, right? So I have no problem at the humeral side for me for the cuff repair. And for the glenoid also, you can tap it deeper, okay, for this why not. So for me, if the patient have osteoporotic bone, I will use why not and put it in the subchondral bone, change the direction, not going perpendicular, but we go into tangential into the subchondral bone. Okay. So for my second question, he asking me about how to do the limb massage to avoid the limitation exhaustion. So as I discussed with Peter, so the way we do limb massage is we doing putting the tendon into the defect, not the muscles. So do not make a very big bite into the muscles. So put in in the tendon, not into the muscles. That would you can remit the external rotation. So that's one question for every speaker about, may I ask the panelists if the bony bank card is big? Do you have any tips on passing your suture medial to the bony bank card fragment? So what's your trick to pass the suture? You pass through the bone or not?
Okay, let's say is a bony fragment is very huge, very
Yes.
big. You can't even pass through. What you can do, you can put the anchor, you can put a suture on superior and inferior to the bone block.
Yeah.
To the bone, then you tie it. So if you have a device like the big bone piercer from some company, you can actually pierce through the bone. That means the needle is very strong enough to pierce through the bone.
Yeah.
But most of the times you need to struggle. Probably you're not able to catch the largest diameter of the bone fragment. Probably slightly inferior or superior to that.
Yeah.
To pass your suture through.
How about you, Peter?
For me, I will do the things a little bit different. I will not only use suture anchor to do the fix the big bony backer. Instead, I will use button, just like the arthroscopic letter J set proposed by scale below. And usually with a big bony banker, the labrum is still intact.
Yeah.
I will put suture anchor in the superior and the inferior to that Prof.Dr.Bancha
Yeah.
induce the suture angle to reduce the Prof.Dr.Bancha first.
Yes.
After Prof.Dr.Bancha is reduced, then I can drill the transosseous tunnel and put the button on the two sides.
Yes.
But without tightening the button, you can still do some manipulation to make that the bony fragment in a perfect position. Then you tighten the button. Then
Oh, you
give
mean
a
the
very-
button in the joint, right, Peter?
the button in the anterior aspect of the glenoid neck and the posterior part of the glenoid, which is
Okay.
a transossous. You need to go from back to front.
You drill to the bone, right?
Yes.
Okay.
Because you are drilling using a drill, then
Yeah.
there's no problem in getting through the hard bone.
Okay.
Yes, I use a very strong suture passer, but even for that, I'm still worried. So I found that this method will be easier for me.
Okay. So for me, I think the portal is very important for when you're dealing with the big piece of bone. You need to use the 5 o'clock portals, okay? Because the direction is like that. You need to pierce through, right? Not like this. If you go like this, you cannot go around. Like you use the 45-degree or you use the 90-degree, you cannot pass through because the big piece of bone. You need to go through it like this, go straight. So your portal, I think, is very important. You put the lower portal like 5, 7 o'clock portal, pierce it through, and then you pass it not through the bone, but at the junction between bone and the labrum. Okay, and very good detach this piece of bone and try to throw the suture. It's not easy to retrieve the suture at the tip of the instrument. You need to throw the suture because it's difficult to find that. So you send the spectrum, the straight one, or if you have the something that have metal inside, that should be fine. Okay, and then you can take the that nitinol, yeah, from these 5 o'clock portals. And I agree with Peter. We need to go above and below the piece of bone because the bone is always like this, right? This is the bone is like this. So in the top and the bottom, the piece of bone is small, but in the middle is big. So try to catch the above and lower first, okay, to reduce it. I agree with Peter about this point. Okay, there's another questions about the in limb research. Better doing not tying after the Bancha repair or before?
I do it after the Bancha repair.
How about you, Peter?
Also, after the Bancha repair.
Okay, second question. In athletes with shoulder instability, with shoulder instability, which indication for surgery during the season or wait out season? In season or wait for out season?
I will advise to wait out season because obviously after surgery we want to protect and let the repair tissue to heal. It takes time, not so fast. So in this case, wait out for season will be better.
How about you, Pavan?
Yeah, I agree because I only allow the athlete back to the sport probably around 6 months after the repair, so definitely it's not during the season.
Okay. Any more questions?
Bancha,
Yes.
you don't have any issue. I have some problem, especially if there's no context. I found it's very difficult to put the Y knot to anchor the Y knot. So that's why I prefer to use a press FT now for this or fresh fracture, not the soft tissue bump cut.
Why?
Yeah,
You don't
because
trust
I
why not?
found that why not when you anchor it's okay. After a while, because there's no cortex on the you basically you go through the raw bone area,
Yes.
cancellous bone. So if there's no cortex, very difficult. You will dislodge the suture again.
Actually, you can put to the opposite cortex, no problem. You can tap it deeper to the opposite side, and when you catch the bone, you can go deeper and then you pull. It will be stable.
Oh, that means you go to the other cortex.
That's right.
Oh, good idea.
Is any contraindications? No, right? Very easy, simple. You go to the opposite cortex, it's very stable. Okay?
Okay.
Yeah. So that's why I love why not. Okay? The name is soft anchor, but it's not soft. It's very strong. Okay?
All right.
Good. So Peter,
Any other
any more
So
questions?
Bancha, I noticed there is a question for you
Yes.
in the Q&A. Maybe
Yes.
I read it for you. It
Yes.
say in the elderly patient shoulder dislocation with large GT fracture.
Yes.
In which case would you do open surgery?
When it's large GT fracture, the problem is that you cannot use a suture anchor to fix that because your anchor, the lateral load should be very low, right? You should put it at the diaphysis of the bone. So that's not safe. Okay, I think for the large bone, it's better to do open surgery. Yeah.
So maybe I add a follow-up question to this. So how big is big?
How big is
Can you
big?
give a size
So
so that the
whenever there
audience
is the triangular shape, you see triangular shape of the bone that extending to the proximal humerus, okay, about 1.5 centimeters. I think more than that, I cannot put the anchor. It's too big. Yeah. So I prefer to
agree?
use the open surgery, deltoid split.
So your
And
open surgery, Bancha, you use a screw fixation or you use a plate?
No, stop using screw fixation. I saw a lot of complication. You make a mini open, right? Then you pass the heavy sutures at the bone tendon junction, and then you do it like parachute. Put it tie in to the small plate or put it on the screw. I prefer to use the small plate, okay? And you put this suture onto the plate. It's like tension band, like that. Yeah,
So
that's
I
my
found
way.
sometimes it's quite tricky because the fracture, although it's in from the GT, but it's more posterior.
Yes,
Sometimes hiding under the acromion.
yes.
Not easy to do that. So what approach you use for this GT fracture?
A deltoid split. I recommend deltoid split because if you coming from deltopectoral, it's too far. You cannot manage the posterior part. So deltoid split is easier. And it's just direct. You open the deltoid split, you can see the fracture right away.
So you split between the anterior and the superior deltoid interval.
Right. I draw the line from the distal clavicle to the acromion in the same line. Then I make a vertical incision. Not transverse like in the book. I think vertical, very simple, parallel to the deltoid fiber. About 2 to 5, 3 centimeter is enough. You can see very well. Okay.
so Bancha, let me have a follow-up question with Dr. Ng question.
Yes.
So suppose you have a chronic GT fracture, which is just like you say, posterior, high under the acromion. You use a split delta approach. What's the trick for you to release it and get it to the front?
So in case we have we have a lot of neglected GT avulsion. So first I will do arthroscopic release because from open surgery you cannot release very well. So from
Agree.
arthroscopic release you can release very nice, right? You can release the collacohumeral ligament. You can release the fragment very nice, okay? And after that you judge again. You need to can you do it arthroscopically or can you do it open? But most of the neglected GT is always small in my experience. It's never big because that big piece cannot go upward, cannot go that far. Okay, it's always small. So in the neglected GT fracture, it's always small piece. So I think nearly 90% of my cases I do arthroscopic surgery for this neglected GT, this fracture. Sometimes it spreads very far.
Bancha, is there any occasion that you find after the release, this negated malunited GT still cannot be get back to the anatomical position? What will you do?
I have one patient that I cannot reduce it back because of the chronic. That patient also have done some plate fixation, a lot of scar tissues. So finally, we need to do reverse for him in that
Yeah, I
patient.
agree.
Yeah.
Agree.
Yeah.
Okay, Bancha, I also see some more question in the Q&A.
Yeah.
Maybe I read out for all of us.
Yes.
The question is, if an elderly patient, example, age 60, had their first episode of dislocation at a much younger age, example, 20 years ago, that means in between there is 40 years. Is there any difference in the management compared to when the first dislocation just happened at the age of 60? That means the first scenario is a repeated dislocation, but the first time is at 40 years ago. Then now 60 old, that is okay. The second scenario is the first dislocation is at the 60 years old. Do you have any difference in the
Yes.
management?
Me first.
Yes, Bancha, go first.
So most of the dislocation, you need to ask when is the first dislocation. So we have many patients that dislocation when he was 20, okay, and he has recurrent dislocation, and sometimes the dislocation stop for many years, and he come back again at 60 and recurrent dislocation. So this patient, we have no cuff tear. In my experience, no cuff tear at all. If they had dislocation first time in the young, okay. So this patient, I will do arthroscopic, label repair, intraarticular is mainly. But first time dislocation in elderly, in 60 years, so you have higher chance of cuff tear, up to 60% from the incidence. So that's my experience.
But Bancha, may I have a follow-up question on this? Will there be any rule for long operative treatment in these two scenarios? That means you don't do surgery, just rehabilitation.
Just rehabilitation. Yeah, we need to discuss with the patient that he can modify his activity and he can stop this dislocation by rehabilitation, exercise, and modify his activity. So I think surgery or not, it depends on the patient. Okay?
Agree.
Yeah, I don't decide for the patient. It's just by themselves.
Dr.
So I agree partly with Bancha. The thing is, if you have a first dislocation younger age and subsequent dislocation at the older age around 40, 60 years old, probably it's just a straightforward dislocation with some labrum injury. But if the traumatic injury first episode in the older people, so there will be associated injury like a cuff tear. So my experience is this sort of patient with the first time dislocation elderly with the cuff tear and the labrum tear. So if there's no bony bronchite or heel sac, probably this sort of case I just go ahead and do some cuff repair. I think after the cuff repair, the shoulder will be stiff enough and dislocation usually is not an issue. That's my personal experience. I'm not sure how's Bancha after you do the instability and also the cuff repair.
Yeah.
Is there any stiffness, any severe stiffness in this organ patient?
No. It tends to dislocate again. It's not stiff. So it depends if the patient have the medium-sized tear. I always repair both because they always have label tear together with the cuff tear. But for the massive tear, rarely I didn't see the label pathology. So just the cuff surgery is enough for this massive tear. You agree?
Yeah, I agree with that.
Yeah.
If you have a massive cuff tear, usually the labrum usually is not a big issue. Usually I don't bother to repair. I just do a cuff repair.
Right.
For me, I would do the things a little bit differently.
Yes.
Actually, I would treat both groups as the same. For a patient coming to me, 60 years old, first time dislocation, I always treat him conservatively, especially he does not have any other symptom. Because I noted that from the literature, the recurrent dislocation rate is well below 15%.
Yeah.
But in case he has persistent pain, then rehabilitation first. Failed the rehabilitation, I will do an MRI. If the MRI does show that there is a full thickness tear, then I will discuss with him about surgery. But the purpose of the surgery is mainly for the treatment of the rotator cuff rather than for dislocation. Yeah, so this is my usual approach.
Do you inject the steroid in this traumatic cuff tear in case the patient come to see you with pain and stiffness?
To be honest, I don't do this.
You don't do that. How about you,
Don't do this.
No, with the with a traumatic injury, I won't put the steroid inside. I won't put steroid. Yeah.
You're afraid of infection, or when you repair the cup, it will not heal? What is your concern?
Yeah, both. I think steroid probably can help to reduce inflammation and pain, but not good for healing. So I won't do that. I
Yeah.
won't do that.
But there's some literatures mentioned about the steroid injection in the cuff tear. You have no problem with the healing. So for me, if the patient have the small size tear, no recurrent dislocation, I will try one shot of steroid injection. If the patient feel better, pain relief, okay, I will do conservative. But most of these cases, they will have the big size tear if they have recurrent dislocation, because small size tear rarely recurrent. Any more questions, Peter and Profeng?
I cannot see further
Yeah.
from the Q&A box.
Okay. So I think so now it's about the time to finish the webinar today. So thank you, Professor Ng and Professor Peter Yao from Hong Kong and Malaysia. And thank you again, everyone, for joining today, the Class Connect webinar. Shoulder Instability Webinar Connect has many more webinars in the store in 2021. So please wait for upcoming events, okay, everyone, and stay safe and healthy. Okay,
Okay. See you.
bye-bye. See you,
See you.
Peter
Bye-bye.
and
Yo.
bye, everyone.
Bye.